I'm Jan Tack. I'm a gastroenterologist in Leuven, Belgium. I'm the head of the gastroenterology and pathology division there. Clinically and scientifically, my interests are disorders of gut-brain interaction, which includes the irritable bowel syndrome. And I'm the president of the Rome Foundations, whose mission statement is to improve the lives of those who suffer from disorders of gut-brain interaction. So IBS is extremely prevalent. Many physicians see it, primary care, specialist care, and there is a hesitance to communicate the diagnosis. Because if you do patient surveys, those who have clear-cut all the requirements to make the diagnosis very often will say, nothing was said to me. And I think there are two things playing a role. One is some diagnostic uncertainty. We come from an era 15 years ago where this was a diagnosis of exclusion and you never have done all the available tests. And now in the international literature and consensus, you can make a positive diagnosis, but many of the colleagues feel actually a little bit uncomfortable. So the idea was to make a tool that aids the physician. He can hold or she can hold this in front of him or herself, look at the criteria, they're very easy, and at the same time talk about them to the patient. So it's a double game, reinforcing the confidence of the physician and allowing the physician to communicate to the patient. And it has to be done in a user-friendly, visually attractive, and of course, evidence and scientifically valid-based approach. And this is what we try to achieve. The diagnosis of IBS is now a positive diagnosis based on two things. Recognition of a typical symptom pattern and duration, and this is embedded in the tool. But it doesn't stop there. Not everybody who sounds to have IBS symptoms has IBS. So there's two other layers actually that come into play. One is looking at alarm symptoms or risk factors. These are elements in the patient's demographic characteristics, for instance, age or family history, or associated symptoms that we think that may be something else than IBS. So there's a checklist of alarm or risk factors. For instance, in Western Europe, age above 55 is viewed as a risk where colorectal cancer starts. We ask about blood in the stools. That is not a sign that is fitting with IBS. And a third layer is a recommendation of which additional testing you could consider. The latter is not obligatory for every patient, but there is a small set of lab tests that are reassuring the diagnosis in some cases where there's a little bit more doubt. That is actually how the diagnostic tool and the spirit of the diagnostic tool is built. Establishing a successful diagnosis relies on a couple of things. First of all, the physician needs to be confident about the diagnosis, and that is recognizing the symptom pattern and its chronicity. If the symptoms are very typical for IBS, pain, discomfort in the abdomen, improved or related to a bowel movement or a change in the bowel pattern and frequency, that is a prerequisite. If this has a slightly longer onset, that reassures the diagnosis. And of course, the physician needs to check for alarm or risk factors. That is part one. But the second part of the successful diagnosis towards the patient is communicating this to the patient. You actually need to make a link with the patient, express the diagnosis, and have the patient accept the diagnosis. And a third one, which is very often forgotten, make a forward-looking plan for treatment. And that doesn't mean that everybody needs a medical therapy. Sometimes reassurance and explanations is enough, but to have a plan towards the future, if there is a need for additional interventions, that could be dietary, could be a pre or a probiotic, could be a medical therapy, could even be a behavioral therapy, all of that exists, but to engage with the patient towards the future management and outcome evaluation. I think this is also part of a successful diagnosis. If you say, we think it's IBS, we recognize it, you explain a little bit, and you don't say, I will be there to assist you in managing these symptoms, you have not gone full circle. The last part is very important, and actually the tool provides input on that. It has a statement, when do you need to see the patient back? And it has several levels of commitment there, but I think this is very appropriate. Yes, I've been in this field for a long time already, and I've seen the view on IBS really evolve. It has evolved from something that physicians mainly said it's not worth to focus on that, just send the patients away, this is nothing. Now we are aware that, first of all, this is a impactful disorder. Second, there are mechanisms that we understand better that are not in the brain. There was a prejudice 30 years ago that maybe all of this was psychosomatic, and I think this is really in the realm of gastroenterology, and it's a task of every gastroenterologist and every primary care physician to know this and to manage it appropriately or refer when it is necessary.